All right, good afternoon, everyone, and welcome to the Perspectives from Recovery Residences webinar, presented by Recovery People and C4 Innovations. My name is Jonathan Cox, and I work for C4 Innovations, and I'll be introducing today's webinar. I'm joined today by Jason, Pace, Erin, and Alicia. Say hi, everyone.
Hi, everyone.
So, as we begin and introduce this webinar, please introduce yourself in the chat box on the screen. Let us know your name, your state, which organization you represent. We will be recording this webinar, and you'll be able to view the recording on the website later this month. During this webinar, all participants will be in listen-only mode. We encourage you to submit questions in the chat pod throughout the webinar, as well as talk with other participants. When we reach the Q&A portion of the webinar, you can submit an anonymous question through the Q&A pod located on the right-hand side of your screen. You can submit questions through the chat box at any time, and we'll do our best to answer as many as possible. Please be aware that any comments in the chat box will be viewed by everyone. Please listen to the webinar using your computer rather than using a phone line. If you have trouble hearing the audio through your computer speakers, please request assistance through the chat box. A member of the team will respond to you via private message. If you'd like to zoom in on the slides we're sharing today, you can make them larger with the full screen button in the upper right corner of that display pod. To exit full screen, just press the escape key on your keyboard. It allows you to view the presentation without the pods or switch back to the pod view so you can pose a question or comment. This session will last for 60 minutes with some time set aside for questions. You'll be able to download today's slides and other resources using the file share pod, which will appear later during the presentation. To download a file, click on it with your cursor and then click Download Files. All right, let's go to, we want to make this as interactive as possible. So why don't we go to our first poll and hear your opinion. So we wanted to think about, some people are prescribed with medication-assisted treatment or MAT, and we wanted to hear your opinion of who should be. What are the characteristics of somebody who should be prescribed with MAT? So you can type your answer into the chat box right on the left-hand side of your screen. Okay, now people, don't be shy. We're all among friends here. Okay. Starting to get a couple of answers. And I've broadcasted the results because this is anonymous. So please feel free to give us your thoughts. All right, we've got a couple of people saying diagnosis of OUD. We've got one person saying chronic pain and OUD. We've got somebody saying anyone who's an injecting user should be prescribed with MAT. One person has come out with those who choose to be on MAT should be on MAT. Another person has suggested for an IV user. Someone else has said chronic pain. Someone has suggested difficulty with relapse. Someone's just written the words long-term. I'm not sure whether that's a long-term user of MAT or a long-term user of any opioids. Multiple overdoses, multiple treatments, long history of use with failed attempts to achieve lasting recovery. Constant relapse. I'm unsure if I said that one before, but certainly a good idea. One person has said pregnancy. I'm going to leave this up for about another few seconds. Okay, one person has suggested the beginning stages of recovery. Another person has said those who choose to be on MAT. All right. right, so we've got some interesting ideas. You know, there's a little bit of variance across the answers. We're going to be having a number of polls throughout this session, so I would encourage you to give us your opinion. There are no wrong answers in this webinar. We're genuinely here, you know, willing to hear whatever someone wants to say. So please, we've got several more polls, so please feel free to give us the benefit of your wisdom and your experience. All right, well, we'll move back to our chat box. And we'll just talk a little bit about introductions and objectives of this webinar. So during this webinar, we're going to identify ways to foster a house culture that is inclusive of MAT along with other recovery pathways. We're going to articulate when and if a residence should change to include individuals who are prescribed with MAT. And then finally, we're going to identify strategies that are responsive to staff and resident concerns about MAT. Throughout the next hour, we're going to explore how a recovery residence examines its culture in light of the opioid epidemic, and then thinks about, you know, any changes that they need to make or whether they need to make them as they move towards a more inclusive environment. And then we're going to think about, you know, it's very easy for people to say this and to decide to do it, but there are some actual practical considerations, some challenges, some issues that people need to think through, and we'll talk a little bit about some of those practical issues as they consider this change. So we're going to talk a little bit about you know, a number of terms, and we thought it was useful to define each of these terms you know, as we use them over the course of the webinar. So when we say recovery residences, we're thinking about a residence that provides a family-like living environment, free from alcohol and illicit drug use. Its approach is centered on peer support and connections that promote recovery from substance use. And when we look at, you know, the range of recovery houses, we're noting that NAR has described 4 levels of recovery residences that range from kind of fully peer, level 1, to more therapeutic residences in level 4. When we talk about MAT, or medication-assisted treatment, we're referring to when people use an FDA-approved medication, such as buprenorphine, methadone, naltrexone, and they're using that to assist a person in addressing a substance use disorder. And then finally, MAR, or medication-assisted recovery. It also refers to using an FDA-approved medication to address a substance use disorder, but also emphasizes a person's commitment to engaging with abstinence-based recovery supports. Okay, let's go to our next poll. This one is a multiple choice one. If you were a recovery resident and you decided to begin accepting people prescribed with MAT, who in your opinion would find it hardest to adapt to that new culture within your residence? Would it be your owner, your senior staff, the staff team as a whole, the residents, the recovery community that surrounds you, everyone? Let's take a moment and vote for that. Okay, we're just going to give you a few more seconds. Okay, we've still got people voting, so I'm going to give you 10 more seconds. Okay, and clearly our most popular answer with more than half the vote is all of the above. Second only to our residents and the recovery community that surrounds you. Interestingly, very few people voted, well, no one voted for staff team as a whole, but very few people voted for senior staff or owner. Interesting. All right. Let's move on and talk a little about cultural change. And Jason and Pace, take it away.
Yeah, thanks, John. I'm Jason Howe with Recovery People, and recovery housing and the culture within recovery housing is a really big passion of mine, so I appreciate being able to speak to this slide. You know, to become proficient at supporting medication-assisted recovery homes are going to have to master cultural change. I mean, looking at that previous slide, that poll, you can see how complex this really is, or it will be. There's wonderful diversity across recovery homes, across the levels, and across the United States, but what all of them will talk about is the importance of the culture within their recovery home. You know, a large part of what we're doing is we're transplanting individuals from their own culture of addiction into a culture of recovery within the recovery home. It's an assimilation, if you will. And a healthy culture drives recovery home outcomes as well as sustainability, and it's probably the most difficult thing to do, from seeding the culture to maintaining the culture and sometimes having to reestablish the culture. From a best practice standpoint, recovery homes develop a symbiotic relationship with the surrounding recovery communities. And again, I think we saw that recognition on the previous poll. And generally that has been the 12-step fellowships and the faith-based communities. Historically, neither of those cultures have embraced opiate agonist treatments, which are two types of MAT. And I really state that without any judgment. It's their culture, it's their right, it's their responsibilities. And I also want to acknowledge that they face the same cultural change challenges that we as recovery housing providers do, if not a lot more. But if you're on this webinar, you understand that there's some people with an opiate use disorder that don't have time to wait for a cultural shift. So the question is, so what do we do today to support them? And it's my belief that just changing a screening policy to allow persons on MAT is not enough. If you're not making the underlying cultural change, you can't act surprised when you welcome someone or when somebody on MAT comes into your home and discontinues the medication because they're assimilating into a culture that doesn't embrace, much less celebrates, a resident's choice to be on MAT. So I really want to stress the importance of thinking about this from a cultural change perspective. And with that, I'll turn it over to Pace.
Thank you, Jason. Hi, everybody. My name is Pace Lawson. I'm also with Recovery People. And I remember, so back in 2014, I opened up a recovery home in Amarillo, Texas. And Jason, I don't know if I've ever told you this, but then 2 or 3 of my friends were like, well, do you know Jason Howe? I said, no. You need to talk to Jason if you're going to open up a recovery home. So I remember there was an application to serve on an advisory board. So I made application to that. And in 2015, I met Jason down in Austin. It's been a journey, and today I'm with Recovery People full-time. Really honored to serve in this capacity. The question we've got up now asks, and this is for everybody, you can throw it there in the chat box, how does a recovery resident build a culture that accepts individuals prescribed MAT while still supporting more traditional paths of recovery, such as the 12 steps? And I'll keep an eye on that. Education. Good, Jose. Open communication. Elizabeth, thank you. Shout out to Jose and Elizabeth. So I'll let y'all keep typing, and I'll keep an eye on that. I do want to give a shout out to Erin Helm. You'll be hearing more from her in a bit. She developed these slides. She's most definitely the expert in the room on this. And from her pondering over this question or this paradox for quite some time and bringing this paradox to life in the Woodrow Project, which you'll also hear a little bit more about later on, we have the following bullet points. Keep in mind, you know, today we really only have time to touch on some of this. Just to kind of put a bug in your ear, we do promise to take a deeper dive into this in the 2020 Learning Collaborative, which John is going to touch on a little bit later. So first and foremost, the adoption of many paths to recovery philosophy. If I glance back over, I see a lot of education, a lot of good success stories, person-centered, some of the evidence about MAT. That's all really important. Like I said, in 2015, I started a nonprofit called Options Recovery, which was built on a multiple pathway philosophy, hence the word options in the name. We didn't adopt an all pathways model. We intentionally left out moderation management. So I like to keep in mind that there's just an enormous array of pathways to recovery. Some fit the recovery housing model, some may not. It's also important to note that, you know, in adopting a multiple pathway philosophy, it's easy when the culture of the recovery home is already pretty broad and inclusive. That's to say not exclusively 12-step, which is the case in most instances. For us, the move to a broader many paths to recovery culture, it came with an inherent intensification in services because each resident was developing an individualized recovery plan. And so the staff, volunteers, leaders in the home would need to spend more time with those residents, really crafting and collaborating on each person's individual path, their journey, their recovery journey. Next, promote acceptance of different opinions. I'll just be honest with you. A little bit about me personally. Although I opened a home that values multiple paths to recovery, I come from a strict 12-step background in my own journey to sobriety, which began in 2007. And I mean like rigid, letter of the law, beating down doors, big book thumping 12-stepper. Like I was hitting up homeless shelters, jails, treatment centers, anyone who would let me in to share the 12 steps the way they were originally intended and written into the big book way back when. So that was me. Then, you know, I eventually came across this continuum of cultural competency. And it ranges from cultural destructiveness to cultural proficiency. And after a careful self-assessment, I discovered that I functioned at a level of cultural incapacity. I was not inclusive of other pathways or of different evidence-based approaches. So since then, I've opened my mind. I founded Options. And in the Learning Collaborative, I hope that, you know, we get a chance to give you a lot more information about this continuum and support you as you move through it and incorporate a multiple pathway model into your home, which we hope will open your business up to a new market. So fostering transparency around successes and challenges. So I think this is going to be quite a unique experience. Wow, check it out, Ralph Fabrizio. That's a robust comment there. Ralph made a great comment over in the chat box. Hey, Ralph. So in the Learning Collaborative, in the 2020 Learning Collaborative, providers are going to be able to get together and discuss some of these successes and challenges. And so I expect that to be, you know, a fairly robust conversation that we'll have at that point starting in January. Establishing links with other MAR-friendly services and supports. Man, there's something that's been very useful for us and for me. There's a technique that's been proven to increase social capital, and it's implemented by many recovery service providers. It's called social identity mapping. And I hope also to take a deep dive into that during the Learning Collaborative. It's a visual model, basically, of a person's social network. It maps education, employment, recovery support, and other relationships with people and institutions that your residents may have or want to build on. It's a living document, if you will. It's developed in collaboration with residents. It identifies objectives and measures progress towards their attainment and growth in social capital, which in many cases, if you make the pivot to being inclusive of people on MAT, will include those more friendly services and supports. And finally, surround residents, the residents with community support. And again, I think the social identity mapping process really kind of comes in handy there as well. So Jason, I'm going to turn it back over to you.
Cool, thanks. And before I jump to this, definitely wanted to acknowledge a lot of the great chat that was going on earlier. I saw, redefining the abstinence, really kind of looking at how we're defining abstinence to be inclusive of medication-assisted recovery. I saw a lot of chat about the importance of education, both inside the home as well as outside the community, and the use of peer-to-peer mentoring. I think those are all amazing comments, and I really appreciate the level of engagement that this group has. This makes it a much better experience for everybody. So now that you're all warmed up from a chat, we're going to move to this next question. If a recovery resident can't provide support to folks prescribed with MAT, where should that person access housing, or where should they access support services? So, so there's. I'm looking at here at the sidebar. People can enter their answers in the chat box. So I see local mental health authority. Yep. Which different states may call that different, but it's kind of a regional mental health authority. Faith-based community, case management through other medical insurance or healthcare organizations. Other providers. If we can't provide a service, then we must actively link them to those providers. Community centers. If we don't have any other options for housing in Kentucky. So I think that, that's really kind of highlighting the part of this question is if we're not getting them connected with housing and support services, then where else are they going to go? And so that's one of the, I think, the driving factors of us looking at recovery housing. I mean, recovery housing has always been this peer-based initiative responding to a need of the community. I mean, this has been, early on in the mid-1800s is when recovery housing formed. Our roots were social entrepreneurs addressing challenges for our community. So I think we have to ask ourselves this question. If we're not currently serving persons on MAT with our recovery housing, where are they going to go? And so how can we adapt our recovery homes or get them connected to other resources in the community? I see a primary doctor may also support. All right, so thanks again for all the interaction, and let's move on to the next slide. Pace. Oops, trigger happy there. Here we go.
So considering and managing change to an MAT integrated recovery residence. And I'm going to invite Aaron to touch on house design. But as far as planning goes, I mean, when you think about transitioning to serving people on MAT, I mean, it comes with a lot of variables. We start thinking about, should we do medication management or should we do medication supervision? What about naloxone training for the staff and residents? What about naloxone inventory and expiration date, staff turnover? So all these variables kind of come into the process of strategic planning around implementing this pivot. And, man, I know for a fact that when we're having these conversations in 2020, when the Learning Collaborative kicks off, we'll really kind of dig into that. Aaron, you're the brilliant mind behind these slides. Really appreciate the work you've done. And I'm curious to know, like, what conversations have you had with providers in Ohio around house design in the transition into serving people on MAT?
Yeah, thanks, Pace. The one thing that we really looked at when we first started with MAT is individual bedrooms. We had always had shared bedrooms, so we definitely looked at that as a portion of the, excuse me, the change when we opened the first house that accepted people on MAT. Additionally, we also had a specific area to store the medication. While we obviously are not pharmacies and whatnot, we needed to be able to have a place that, because previously all of our residents kept their own medication in lock boxes with locks on them, but we needed to be able to have a place that they could be stored outside of just the room. Additionally, we also looked at having a specific place in the house that we've always had a area that people could have one-on-one conversations behind closed doors, but making sure that really exists and that it's fundamentally a part of the house. So it wasn't a huge change, and I think some recovery houses probably already have individual bedrooms and whatnot. But that was part of what we looked at with the first house. Now we operate 6 recovery houses, and all 6 of them support residents who are on MAR. But a little bit of that was initially getting our feet wet and really working through some of the process that we had. The other part that went into house design, this house, we specifically looked for it to be close to a pharmacy because initially we had contemplated the idea of the resident having to go to the pharmacy daily to get their medication. That is not something we ended up going through with, but I know there was another organization that had done that. So that was location was important for us when we were looking at the house. Like I said, we never ended up following through on that. We found other ways to make it work. And being in the northeast part of Ohio, we have about 3 inches of snow on the ground now. So asking somebody to walk to the pharmacy daily to get their medication seemed unrealistic. But it was one of the ideas that we had contemplated because of some of the fears that we had that were unrealistic fears initially, but we were able to work through that. So nobody's walking to the pharmacy daily.
Yeah, thanks for jumping in on that. I knew you would nail it. So truly appreciate that. As everybody can tell, I mean, Aaron's going to be a huge resource for you. If you've already made that pivot or if you're going to move in that direction, yeah, thanks again, Aaron. So Jason's fixing to dive into policies and procedures, but I'll touch on referrals and applicants right quick because, I know that opening channels of communication with providers is like super important and getting the proper consents in place, and not also to help screen applicants, but also to help monitor progress along the way. Methadone clinics and OBOT, they do some pretty intensive drug tests. I mean, better than any cup or dipstick I've ever used. They partner with labs that are able to differentiate between opioids and show levels, which I think is critical information. Yeah, Jason, I'm going to turn it back over to you, bud. Thank you.
Sure. I'll do a deeper dive here in policies and procedures. And really, there's lots of things to think about when you're adapting your recovery home for persons on medication-assisted treatment. We've already touched a little bit on this around medication storage and safe handling. Diversion risk management kind of folds in there as well. Preventing and addressing relapse, and that's true for any recovery residents, but with an opiate overdose, it can be even more, it's scarier. I mean, the lethality of an opiate overdose is much higher. So really focusing on those areas. New staff responsibilities, or maybe we should say staff's new responsibilities, because if your staff is not a customer, has not had the responsibility of managing medications, then they need to understand the differences between medication management versus medication supervision, and we really need to be looking at your state laws around that. You could be triggering some licensure, and we want to make sure that we are staying within our scope of practice, and at the same time, supporting everyone in the house, the individual on medication-assisted treatment, the rest of the residents, as well as the staff themselves. And then the last point is looking at policies and procedures around managing stigma. And if stigma is a term that works for you, great. I know that it can be a bit of a charged word. In some cases, I've seen it being weaponized. And so maybe you reframe it and call it up, managing different perspectives on MAT within the home, managing different cultures or recovery pathways considering MAT within the home. So it's really, you kind of have to look at your own culture and develop policies and procedures that are going to be best for your home. And I see we've got a lot of really good participation in the chat room. Wow, I'm trying to digest everything that Ralph has written there. I really appreciate all the participation that everybody has been including. Maybe for time's sake, we'll go ahead and click to the next slide. Pace?
Yeah, Jason, I'm here, but my for some reason the application crashed. I'm bringing it back up. Sorry. Can you hear me?
Yeah, we can hear you loud and clear. So go for it.
All right, I'm back. It's coming back up on my screen now.
So while Pace is figuring out his screen, perhaps I'll read out the next chat question. If a recovery residence makes a change to accept individuals prescribed with MAT, what can the local recovery community do to support the residents? So let's hear your words of wisdom on this one, and I'll hand you back to Pace.
Okay, yeah, cool. So the question is, if a recovery residence makes a change to accept individuals prescribed MAT, what can the local recovery community do to support the residents as a whole? Let's see. Recovery community as in the 12-step fellowships or clinical community? I would say all recovery community, including that entire network, up through clinicians. Make MAR meetings available in the area? Sure. I mean, I'm always looking for passionate people who are wanting to start support groups like that and then providing them support to help them get going. That's always exciting. Erase the stigma of people on MAT. Being a part of a 12-step fellowship community, that can be kind of touchy in my experience, and sponsor 12-step participants who are prescribed medications to support recovery. Yeah, just invite them in. Yeah, sure. I mean, that's ideal. Not always easy, but definitely ideal. These are some good answers. Create focus groups. Yeah, definitely. Provide mentors and sponsors, education. Make MAR meetings available to the whole recovery community, accountability partners. Good stuff, y'all. Great participation. How about some town hall meetings? That would be cool. That's kind of outside my scope of practice. It's pretty intense to organize and get those going, but for sure, I'd love to be a part of that. All right. Good question.
John, I think we'll go ahead and turn it over to you, because I think that probably the best part of this presentation is going to be the interview with Aaron and Alicia.
All right. Thank you, Pace. Thank you, Jason. So we're gonna do the next section of this webinar kind of interview style, and it's a real honor to have Aaron and Alicia from the Woodrow Project. Aaron, Alicia, why don't you introduce yourselves?
My name's Erin Helms. I'm the director of the Woodrow Project.
I'm Alicia. I'm a resident at one of the Woodrow Project houses.
Great, thank you. All right, well, let's kick off with some questions. Aaron, could you start by giving us a little background about the Woodrow Project and the house that you're both involved in?
Sure, yeah, thanks for having us. I started, I'm a person in long-term recovery, and used to work at inpatient treatment centers, one in Minnesota, and then moved back to Ohio and worked here, and really saw a lack of quality recovery housing for women. So prior to coming into recovery, I worked in international finance, so had a little bit of a background in finance, was able to take some of those skills and put them to good use again. And we started our first house, and it was a very strict 12-step, only a little bit of what Pace was describing. And you know, we did pretty well. We got to serve some women, and we're continuously on a wait list. So as we began to do the work for some time, I did see some folks that had lived at our house and, you know, for whatever reason were referred to a higher level of support because we just couldn't make it work. And oftentimes it was those with opiate use disorders that they needed a bit more time and or they needed a bit more support. And Cuyahoga County has been very has been hit really hard by the opiate epidemic and saw, quite frankly, quite a few people die. And it just seemed like there's got to be something better that we could do from our recovery housing standpoint. So we got together and looked at opening a house strictly for supporting residents on MAT. And being totally transparent, we had 2 residents who moved in, and then there was nobody. So we actually went back to the drawing board and decided to allow people who were not on MAT to also live in the house. And what a blessing that was, because that kind of laid the groundwork to being able to have MAT in all of our recovery houses, because we saw that it could work in the first one. And it was a matter of just going step by step. Education was huge for our staff to being able to make that transition to that acceptance piece and really being able to work with folks across the board to being able to meet their needs.
Thanks, Erin. Alicia, let's turn to you for a moment. And would you like to tell everyone how long you've been at the house and a little about your daily routine there?
Well, I've been there since July, and I came initially at the beginning of 2017 and have kind of struggled with relapse this time and finally choosing to be on Suboxone has been since July. And my daily routine varies from working to today I had aftercare, meeting with my sponsor, going to 12-step meetings, doing service work, doing fellowship, beginning to spend time with my family. It varies, but it's every part of my life is based in recovery.
Cool. Thanks. And can you tell us a little bit about, why you decided to ask a doctor to prescribe MAT for you, and how following a MAR-focused recovery has kind of both helped you and been a challenge for you?
So I have been an opiate addict, intravenous heroin user since I was 18. I'm 30. And so I've tried this multiple times. I was only able to get really any amount of time once I began coming to recovery housing. So I was struggling to find a house actually who would accept my seizure medication. And I couldn't find anywhere that would take me while I was prescribed gabapentin. So the Woodrow Project, I initially went there because of that in 2017. I had 6 months. I was able to do very well. Relapse had 20 months and did well again, but I promised myself that if I relapsed again that I wanted to try to do Suboxone. I personally had some bias against it, thinking that I think it's a bit of a cognitive distortion of that all or nothing, that perfectionism, that I can do it without, and it's not a matter of will. If you know the disease concept, and it's not weakness. And the recovery housing is very much the holistic approach, and it just supplements my program. It's not the answer in and of itself. I needed to be doing a ton of other things, but it's just added support. My twin brother overdosed and died in 2016. He was on Suboxone, but he was not in recovery housing, and he didn't have the holistic approach. I know that alone is not going to solve the problem, but it can be helpful, reducing cravings, and just an added kind of safety net.
Thanks, Alicia.
Mm-hmm.
Erin, let's come back to you. Can you tell us a little bit about your house, what level it is, and then what changes you kind of made to it, both in terms of routine and policies and procedures, when you decided to make your house available to more than one path to recovery?
Sure. I think the first thing to recognize and to state is we always talked about multiple pathways to recovery, and really we weren't truly living that. So it was, we would say, yes, you can come and live here, but you have to follow these very strict guidelines, quite frankly, of going to 12-step meetings only, and really at that, even just AA meetings, because AA is so prevalent in our area. And over the course of going to Ohio Recovery Housing meetings and NAR conference and whatnot, I heard other people being able to really live that multiple pathways to recovery and it really being, it actually happening. And so that's really, I started thinking about that. And some of the changes that we implemented, like I said, we opened a second house specifically just for MAT. And that house was, it ran very well. We've had residents who have been on methadone. We've had residents who have been on Suboxone. And we've always allowed Vivitrol at any of the houses. So the biggest thing that, as I had talked about a little bit earlier, is we did go with the individual bedrooms. Because we have had such a tremendous wait list, we actually changed one of the bedrooms at that house that was large enough into a shared bedroom. So there are 3 individual bedrooms and 1 shared bedroom. That and we've allowed and supported residents to be on medication-assisted treatment in that house. Because the medication is locked in a safe, we had found this lock that was that you could only open the safe with a phone, with the house manager's phone. And I got to say, it did not work very well. We constantly were running into problems. So we just went with a standard gun safe, and it's worked very well to be able to keep it. And it hasn't been a terribly huge expense. The other part is the training for our house managers and also talking to the residents when they first move in. There's an expectation that they sign releases of information for their wherever they're receiving their medication. The next part is that if somebody comes in on too high of a dose for their medication, that we're going to talk to them about it. We're not going to pretend that it's not happening, or that, nope, you just got to leave because you're nodding out. I truly believe that people do want to get well, and it's being able to support them through the fear of, maybe you're on too high of a dose. And having conversations. We use peer support in every one of our houses, so it's a non-judgmental approach of, are you feeling tired, during the middle of the day? You're 23 years old and can't seem to make it through the day without a nap. And some of that is teasing out is something post-acute withdrawal symptoms? Is it some trauma? Is, what's actually going on? But having the peer supporters go with the resident to doctor's appointments, and we've never had a doctor that has said no, and honestly, we've never had a resident who has said no to that assistance, because most people want help. They want to get better. Even residents who have relapsed, they still want to get better. And if we can really treat it as a disease, then, and being able to follow through with the support from the recovery community. When we started this first house, I talked to people that I knew in the recovery community and said, you've been very accepting of supporting residents that we've had living in the house with sponsorship and whatnot. What are your thoughts on working with somebody that's prescribed to MAT? And I was surprised at how many folks said, after some conversation and some education and knowing, that they were going to be supported, they said yes. So we have, after, I don't know, probably 3 or 4 conversations, we've never had an issue with a resident finding a sponsor if they choose to go the 12-step route. So I think breaking down a lot of the fears was a huge part initially, and still continues to be, because obviously we get new residents all the time. So being able to talk to them. The other part of it is we've always had a pretty strict policy on your medication is your medication. The only people you need to talk to about are your doctors, the house manager, peer support, and your sponsor. And there's really nobody else that you need to talk to about that. So, and that is with whether you have an antidepressant or you're on Suboxone. So being able to have those and treating all medications that way, I think is important. We look at people who are on medication-assisted treatment as abstinence-based as well because they're taking a medication as prescribed. So I think a lot of that's perception, and it does start from the top of the organization down as long as you talk to your staff about it and allow them to voice their concerns and really support their concerns as well.
And Erin, just the way you said that, the way you used the term house manager, am I right in thinking that your houses are level 2s?
Oh yes, all of our houses, we are level 2s. We do have one level 1 recovery house, and we do have a resident who's living in there who is on medication-assisted treatment. She has been in recovery for almost 2 years, and she's still on medication-assisted treatment and doing beautifully.
Cool. Thank you. And Erin, you've partially answered my next question, but I'd like to hear yours and perhaps Alicia's opinions that, you know, for many folks who are recovery housing owner-operators, their two worries are projects that will have folks nodding out, and I think you've answered that. But also, you know, the idea that someone who follows a male-focused recovery will kind of tempt folks, whether consciously or often unconsciously, they'll tempt folks who aren't prescribed with MAT into illegal use. What has your experience been with that?
We have not had that at all.
Mm-hmm.
We have had residents who have moved into the house and have been on MAT, but I think the biggest thing is most of the other residents don't know that they're on medication-assisted treatment. So it's not this, you can't see it. So that whole idea of tempting, it's not seeing somebody nodding out. It's not seeing somebody going from being real low to being kind of high. I mean, quite frankly, or those effects that come along with opiate use disorder. So having the right prescription is important. The other thing that we have said is there's a certain level of medication-assisted treatment that we can support. We really don't work with folks who are on, because by the time they get to us, they need to be in the maintenance phase early, but we are not part of a detox or anything like that. So the residents need to be on about 8 milligrams, 12 milligrams at the absolute most, but we're not working with residents who are on 24 milligrams or 16 milligrams because that's not our level of support, and knowing what we can and can't do is vital. Yeah. So we're not looking to work with somebody that's on 16, that they're still trying to find the dose that's the right dose. It needs to already be figured out by the time they get to us. Mm-hmm. Alicia, do you?
Yeah, just from my experience from being on it, I've never had anybody question me. There hasn't been any indication from my behavior, I'm sure, that I'm on anything different than what, you know, I'm on an antidepressant. You know, I take a seizure medication, I take an MAT, and it's nobody's business. That's a medical thing, and that's my choice. My sponsor knows. But like Erin had said about the abstinence space, like I don't feel like, because I work a 12-step program, I don't feel like that's mutually exclusive whatsoever. Like I've been able to work with it just fine. I don't have like any kind of nodding out. No one has ever guessed or known or been like, hey, you know, ever. So, yeah.
And I do see I was just going to say, I see a question in the chat box about why we felt it was important for single rooms for MAT residents. Initially, we started out that way because a little bit of my own fear of if somebody was going to be nodding, them going to their room and being able to be in their own room. That is not something that we have still going on. We have residents who are in shared rooms who are on medication-assisted treatment. But when we started, we tried to put into place any any support possible to be able to help the person make it work. And we've learned through the experience over the past 3 years that shared room works just as well as what an individual room does.
All right. Erin, Alicia, I could spend the next 2 hours asking you questions, but probably you get a little bored. But one thing that's made me curious, and I'm not sure if this is an issue or not, we know that peer support is a core value in recovery residences. You know, no matter the shape, style, structure of the house, it's integral. As Jason always says, it's the secret sauce. So how do folks who follow a 12-step approach support individuals who are following a MAR-based recovery approach, and kind of vice versa?
So I think what Alicia had said is we don't find them to be mutually exclusive. All of our peer supporters have the education regarding what a MAR approach is. We also have residents who are living in our house that go to Celebrate Recovery or Refuge Recovery. Our peer supporters, I don't expect them to be experts in Buddhism, Christianity, any of those, but they need to have that cultural competence of recognizing that this is a spiritual pathway, these are medications, and being able to ask the questions when they don't. I'm not going to say that I know everything, but I've been able to, I've been around for a lot longer than some of our peer supporters have, and being able to get the answers when we have a question that arises. So we really take a team approach with each resident. The peer supporter obviously knows them the best, and then kind of working up from there to be able to support the resident in making those decisions. And that part of the MAR is a part of their recovery, but it's not all their recovery.
I've been supported, I feel, in much the same way that I was without it. I don't know, it hasn't been like, because I'm on the medication, there's been a wildly different approach, or even much of a different approach, I would say, at all. If there's issues with my medication, I go to my doctor. I talk to my sponsor about it. My peer supporter is aware and supportive of, and always there to listen whatever comes up. But yeah, it's not like there needs to be some drastic change in the support, because it is a very small part of my recovery. My recovery consists of so much more than that. That's just an added support. It's not the primary focus.
And speaking for Alicia, she also has had some significant grief and trauma as well, yeah. And she's dealing with those with an individual therapist. And I have to say, in the past, she has started to, but it's kind of building blocks that it feels right now that we found the right supports that she's needed to be able to really find the freedom that everybody's looking for.
Amen. Yes.
Well, Alicia, there are many flattering things. I say flattering, I think they're all true, written about you both in the comments box. So I want to add my thanks for your honest and forthright answers to the questions. So we're going to skip over the next call, and I'm going to hand you back to Jason. Jason, you are muted.
This would help if I'm unmuted. What I was saying is thanks, John, and I just wanted to echo the thanks, Alicia. You know, the recovery community, we learn through story, and so I think it's really important for us to hear from people like yourself that is pursuing medication-assisted recovery and doing, well. So thank you for being a voice to that. And when we come to the question of so how do we move recovery housing to a place where it's proficient at supporting persons on medication-assisted treatment, and the answer is it's complicated. And we've just been able to kind of touch the very surface of things, which is why Recovery People and C4 Innovations has developed a learning collaborative, a community of practice. It'll be over a 6-week period, and it is going to be on Fridays from January 10th through February 14th. at noon Central Time, so you're going to have to adjust. I know that we have folks from the East Coast all the way to the Pacific Coast on the line today. But, you know, there's no didactic conversation that we can have, or didactic presentation, or a checklist that is going to get any recovery housing provider to proficiency. We're really pioneering things, and so we need to have a discussion. Things that, you know, participants will be able to expect in the Learning Collaborative, you know, shared knowledge from expert facilitators, and probably most importantly, the other participants, the recovery housing participants. You know, we've got to explore identifying and creating recovery housing environments for people using MAT, you know, that's fostering MAT inclusive culture, ensuring safety for that resident, the other residents, and staff, especially for those who've had a negative experience with MAT. And then how do we facilitate those dialogues and those connections with MAT prescribers and recovery homes? We've historically not done that, and it's key to the success of proficient recovery housing. And then the sustainability plan. There's lots to unpack around this. You know, where are your referrals going to come from? How will this impact your referrals? If we need to adjust the number of beds in the home, how does that impact break even? So there's lots of things to unpack. So I would encourage you, if you're interested in this, you can download information, a flyer from the shared file. I would recommend that you register sooner than later, because we're only going to take 25 individuals. If this is going to be a learning collaborative, and if we have dialogue, really we wanted to limit the number of folks. And who we're looking for is individuals that have recovery housing experience. This is not about, you know, how do you start a recovery home. That's a different conversation. This is a more advanced learning collaborative. People that have experience around recovery housing and that are currently pioneering or are looking to pioneer proficient recovery housing regards medication-assisted treatment. So let's see. Aaron Helms says, can I put my email address in the chat box for further questions? Oh, I guess that was probably a question for John. I don't have a problem with it, Aaron. What else have I missed around the Learning Collaborative, guys, that we want to communicate to the audience?
I think you pretty much covered it. You know, have a look. The link will be up. Take a look at it. You know, there's a cost in terms of financial and time, particularly time. This is not a sit back, feet on desk, and, you know, and educate me. This is we're learning together, so that everything that we do together is greater than the sum than our individual efforts. So with that, I'm going to move us to Q&A. Can we put up we've got the file share pod, so those of you that want the slides and the more information can feel free to download those. And then if you've any questions, feel free to either type them in the chat box, type them in the Q&A, and you know, we'll be happy to answer them. Okay, so I've had a couple of questions come through, and this one can be answered by anyone. If I'm going to change my residence to be MAR friendly, what are the first steps I should take? Jump in, all of you.
So the first step for us was education. I went to multiple seminars and talked to a variety of different physicians as well as counselors. Our area was very slow in treatment providers having medication-assisted treatment. Still right now, 2 of the largest treatment providers in our area do not provide medication-assisted treatment. So it feels like we were a little bit behind the game, but we did have some doctors out there and doctors who were actually spending time with their patients and whatnot when they would put on a presentation. Those were the first people that we spoke with and listened to what they had to say and asked questions about the process.
Okay. We've had a comment come through our Q&A pod, which says policies and procedures changes. Staff has to be accepting. I'd be interested to hear your opinion on that, and also yours, Pace, as someone who's run a recovery residence. How challenging was it for people to be accepting? Go ahead.
On the first question, I would say first, really get a safe and secure policy around medicine, whether it's supervision or managing the medicine. And Aaron talked about having a gun safe. We bolted individualized lock boxes in the shelves in the closet for each individual resident to manage their own medicines, and we would just supervise the logs. So I would definitely look at that first and foremost as a first step. And your second question, was it around the community at large, John, as far as
more around staff acceptance of changing policies and procedures?
Oh, okay. Well, the staff in my case was minimal. I mean, it was me, a program manager, and a house manager, and then the 6 residents. So we didn't have any pushback on that.
Yeah, this is Jason, and I'll jump in there because I think this is getting to what I was talking about, cultural change. So just because the owner-operator decides, all right, we're going to start accepting MAT and we're making this top-down decision, there may be a cultural backlash. And then, there'll be collateral damage if you're accepting a person on MAT, bringing it into a home where the staff is not supportive or the other residents are not supportive. And so you really need to think through how can we engage staff and the other residents in a conversation around supporting persons on MAT and really look at cultivating that culture change. I'm trying to think of better words, but a top-down approach is not the only thing that's going to work.
And I have to second what Jason says. A bit of the, so not only the education piece, but being able to create a safe environment for our staff to ask questions and for them to really feel heard. I mean, that's part of the reason we didn't just go to all of the houses initially from the beginning. It was a gradual change. Additionally, we had, I don't want to say competing ideas, but we really presented the opportunity for, so I always go to, I remember one of our house managers said to one of the other ones, in the big book where it says sought outside help where necessary, and being able to really, if you're going to use the big book as your reason to not allow medication-assisted treatment, then we're going to use the entire text to be able to look at the issue. So that part of it, and various literature, because let's face it, that was written in 1939. So let's go through and look at the whole scope. But it was important to support our house managers in the discussion from without fear of reprisal, that they were going to say something and they were going to quote unquote be in trouble or something like that. They had to be supported.
All right. Well, our time has come, and unfortunately we won't be able to get into any further questions. But on behalf of the Woodrow Project, recovery people, and C4 Innovations, I'd like to thank you all very much for attending this webinar, and please come and hang out with us in January too. But on behalf of everyone, thank you all very much, and goodbye.